Maybe I'm gonna. Thanks a lot, Nigel, for these kind words. Can you hear me well? Okay, so I'm Sophie Delaunay, and indeed I'm absolutely delighted to be here with you today. When I was preparing for this meeting, I thought you guys are the most informed people that we can meet. So I'm not, how can I talk about MSF in terms that can be new to you, or that, or what is the kind of information that you may not have and that could be of interest. So I'm going to try to start with a brief presentation of the institution as a whole, and then I will focus on the operations, but I'd like to share with you mostly the debates, the issues, the questions that animate the organization and the challenges that we face, things that you wouldn't find on our website or or on the web. So I represent the US branch of Doctors Without Borders, MSF, Médecins Sans Frontières. The US is one of the 28 chapters of the organization. Within these 28 chapters, there are 5 what we call operational centers. They are actually the first 5 historically created chapters, and they are the ones to run the operations in the ground. And the additional chapters that have been created over these past 4 years are supporting those operations. There has been a sort of a deal negotiated in the organization that anybody who wanted to create an MSF chapter in a country would have the ability to do so, according to a number of criteria, of course, but that we would stick to 5 operational centers on the ground, so that the countries, it's already hard to negotiate with five MSF sections, so imagine if it proliferates without control. So we have 5 operational centers, and the US is not an operational center, but it's the largest chapter in the MSF movement, and it supports the movement in terms of financial contribution, but also human resources, communication, advocacy, and some medical expertise. And the reason why we're able to play such a role for MSF in supporting our field operation is actually because in the US we benefit from enormous contributions from the public and from organizations like you. Our partnership with Google has been going on for many years, as Nigel said, and it's been in the form of both technical support, technical expertise, and financial support. And I have to say that both are equally valuable to us. In 2015 only, MSF has received $5 million from Google, mostly in the form of matching gifts, so from you. So, and we also received in 2015 2.5 million from Larry Page and his spouse. So needless to say that you are a very important contributor, and it's an opportunity for me to thank you for your loyal and generous support. So as you will see in my presentation, there are, of course, many challenges that we need to address if we want to respond effectively to humanitarian crisis. But we all know, because we're all very pragmatic, that we can't move ideas, we can't move good ideas and mobilize committed people without the financial means. So that's why I wanted to start with this aspect and express our gratitude for the trust that we've received from you. Now, a quick introduction on the organization. As I said, we have about 28 offices around the world. Those offices are supporting the operations, and we're working in about 70 countries. The model that we've chosen for our organization is a very decentralized model, and there is no real headquarters in MSF. There is a secretariat in Geneva whose goal is to coordinate and to ensure that at least our policies are aligned. So we have a human resource policy, so that to make sure that a US physician and a Japanese physician, when they meet in the field, and if they compare salary, they don't enter a big fight, right? So that they are treated equitably. So we have a number of international policies to make sure that we're a responsible employer, to make sure that we're using the same medical protocols, to make sure that we develop some tools that can benefit everyone. But at the same time, we are very much attached to our decentralized model. And I have in mind a few examples that have proved over the years that the decentralized model is hard to manage because, of course, when everybody has a say in the decision, it's not easy, but it's also very valuable in terms of advancing the quality of medical care. For example, we've been able over the years to develop a treatment for malnutrition that has been a real game changer. I'm sure you've heard about the ready-to-use therapeutic food, the Plumpy Nut, and how it has completely changed the treatment for malnutrition. This would not have been possible if we had had one operational center. Because it's because one operational center decided that what the other was doing was not good enough that we ended up challenging our own protocols. And it's true in many areas where we work. In malaria, we've also, because some operational centers decided to take the risk of exploring different approaches and then confronting, having a sort of healthy competition and constantly critically challenging ourselves, that we've been able to improve our own practice. Ebola is also a good example because, as you know, we also have to make sure that we spend our money effectively. So there is always a tension between the right balance between redundancies and duplication. And some years ago, based on our operational volume, we agreed that we all needed to keep a strong capacity in surgery, a strong capacity in malaria, in vaccination, but there were some diseases for which we didn't need 5 operational centers or 28 sections to invest in. And hemorrhagic fever was one of them. Because at that time, we were confronted with very small outbreaks here and there every 2-3 years in West Africa. And we say, okay, why wouldn't we ask MSF Belgium, because they already have a sort of expertise, to be in charge of hemorrhagic fever? And they've been in charge, and they've developed their know-how. And whenever there was an outbreak, it was the Belgium who were going for the response. And the other sections actually did not really invest in this area. We first started to have a problem with that some years ago when there was an Ebola and Lassa fever outbreak in Uganda, and it was the French section who was there. And the team was very powerless in dealing with it. And it took several days and weeks to actually catch up with the knowledge that had been accumulated in Belgium. And it's been even more difficult recently in West Africa. It has actually slowed our ability to scale up because we didn't have capitalized enough within the organization the knowledge of Ebola. And the Belgium were very prompt to respond. They did a fantastic work. But if we had had the full movement up to speed on Ebola at that time, I think we would have done better. So it's a lesson for us that we should not duplicate everything, but redundancies are very important in order to respond to massive and large-scale operations. Now, when you hear about MSF, I'm sure you've heard this sacrosanct principle: neutrality, impartiality, and independence. It really defines our culture and our identity. But let's be honest, these words mean nothing if they are taken out of the context. What's important in these words is more the practical implication that they have if you implement them. So impartiality is at the core of medical ethics, of course, because if you provide medical care regardless of race, political agenda, regardless of gender, then you are able to do medicine in an ethical way. But in our own situation, if you practice medical care with impartiality, that is, if you don't ask for which faction the person works, then you are able to access the conflict zones. So impartiality for us is not just a principle, it's also a very practical way to access those dangerous areas and to demonstrate that we are neutral and that we are not taking side in the conflict and that we have no other agenda than treating the people. And actually, those principles are our main negotiation tools in the field. So how do you get trust from the communities and from the factions that are present there if you are able to demonstrate that you can effectively provide quality medical care, impartial care, and that regardless of who they are? But how are you able to do that? You're only able to do that if you are independent, if you are prompt enough in responding to the conflict, if you're not effectively affiliated with political powers. It's not just about saying it, it's really about being in this situation. And how do you avoid being affiliated with a power is with your financial independence most of the time. So that's why independence is also a tool for impartiality, that itself is a tool for access. How do we achieve our financial independence? We've made the choice a number of years ago not to exceed a certain portion of public institutional funding. What I mean by public institutional funding is government funding. So we don't exceed 15% of funding, which means that 85% of our resources come from private fundings, which gives us a lot of leverage and ability to react in emergencies without being perceived as affiliated with a power that may be involved in the conflict. So there are governments we don't take money from, the US government, the French government, because they have so many stakes in most of the conflicts where we work. And there are governments we take money from based on their distance and if there is no risk of perception that we would be affiliated. The second aspect that allows us to be independent is the nature of the funding. We've opened these 28 offices, as I showed in the previous slide, and this was a way also not to be dependent only on one or two. The US is already a very, very big player, but we don't want the US to become the largest contributor for MSF, because if there is a financial crisis in the US tomorrow, we will have to close our operations, and this is not what we want. So we've experienced this in the past. Spain was our third largest contributor, MSF Spain. But with the economic crisis, we've been able to compensate from a growth in Hong Kong, Australia, and some successes in the US. So diversification and also general funding, unearmarked funding, is what allows us to stay independent. Because when an emergency occurs, you don't need to wait for your team to write a proposal. You don't need to wait for a government to give you the grant. You can intervene right away based on the needs that you identify on the ground. So I just wanted to put a bit of flesh around these principles, because they are actually very practical principles that allow us to do our work. Now let's move to operations. So this is the slide that shows you how our international funding is separated. So in 2013, we have a cap of 15%, but actually in 2013, we only had 9% of our funding that would come from institutions and governments, and the rest would come from individuals or corporations, what we call private funding, which gives us a lot of ability to operate and a lot of independence and freedom to focus on the humanitarian issues. It depoliticizes our funding and our intervention. So what are the main context? Here on the slide you see all the countries where we have operations. 2/3 of our presence is based in Africa, which is where you have most of the context that define an MSF operation. So what would trigger an intervention of MSF? It's mostly conflict or unstable areas with a number of humanitarian consequences like displaced and lack of access to health care or violence and wounded. The second context is neglected disease or epidemics. So the conflict, of course, you all have in mind Yemen, Somalia, South Sudan, Sudan, Syria, but also the neighboring countries. For example, Ethiopia is not at war, but Ethiopia hosts a very large number of displaced people. So we're working in Ethiopia as a result of a crisis. Same for Jordan, Lebanon, at the moment, who receive a large amount of Syrian refugees. Neglected disease and outbreaks are also are also a number of issues that would trigger an intervention. Of course, Ebola is a good example. These countries were not at war, but they faced an unprecedented crisis for which the national health system was not capable of responding alone. We also intervene in times of outbreaks. For example, for many, many years, until there was a vaccine that proved effective, we intervene every 3 years almost in the meningitis belt of Africa. There were meningitis outbreaks all the time, and we would go every year and use this vaccine that would be effective for 3 years, and then every 3 years we had to go back. Now we have vaccine that is effective for 10 years, so we have less reasons to do so. But you have constantly, especially in countries at war or in unstable countries, the health system is dysfunctional. So you regularly have cholera outbreaks or measles outbreaks that necessitate an intervention. And neglected disease is something that we want to keep an eye on because there are a number of diseases that kill millions of people, although we don't experience them in our countries, and therefore there is very limited attention to them. So this is the case of Chagas, of sleeping sickness, of Kala-Azar, who are very neglected, and for us it's a kind of political statement to continue keep an eye on this. It's not a matter of covering a whole population, but it's really shedding a light on this neglect. So just to finish with the scope of activity, and then I will move to the challenges that we face on any given day to give you an idea of the scale. We have about 35 volunteers and staff on the ground to work. MSF is perceived very much as an international organization, which we are, and as a Western organization. But actually, when you look at these figures, you have to know that 90% of these 35,000 volunteers are national staff. Only 10% are international. So the lion's share of the work that is being done by our organization is being done by the local population who work with us. We work in about 70 countries, and we have usually several projects per countries, and a total of, it oscillates depending on the years between 300 and 500 projects, locations for our programs. We could do more, but our goal is not necessarily a goal of covering all the needs. We don't want to be the Ministry of Health of the world. Our goal sometimes is really to identify the most acute places. Our goal is also to have other organizations being able to get involved, take over the needs. Being alone in a place is certainly not satisfactory for us, because we feel that then this place becomes totally dependent on MSF. So it's more about testing new approaches, challenging the status quo, shedding a light on a problem that will define the scale of our operation. And of course, if there is nobody, like Ebola again is a good example, if you have no other organization and you are overwhelmed with the need, you're going to constantly scale up your operations. But it's not an end in itself for us to do large coverage in a country. In terms of result, I don't know if we can talk about impact, but it's the result. Every year we do between 8 and 10 million medical consultation. And the figures that follow are actually interesting because if you talk about a malaria case treated, a surgical procedure, a baby delivered, measles vaccination, or severe malnutrition, you talk about lives saved. Because if you don't get treated for measles or vaccinated, it's very lethal. The baby delivered, you know that in the countries where we work, most women deliver at home. So the babies we are taking care of are the complicated deliveries. are the deliveries that, if they are not assisted, either the mother or the baby or both are going to die. So this is why we actually have a particular focus. We follow a very large number of figures and indicators, but these ones are really the ones that mean a lot to us in terms of lives that we've been able to save. So I've moved that already. So now I'd like to move to the challenges that we faced over the years. The first challenge, and maybe it's go back to this conflict and high security, is the accumulation of crises. I have the feeling every year, at the end of the year, when I meet with a number of donors, and I'm always asked, so how was this year? Every time I hear myself saying it's been an exceptional year. But actually, and I know why it is. It is because most of the crises we work in rarely stop. Even in Haiti, Haiti is still suffering from the aftermath of the earthquake. Most of the crises, they continue, because if you're talking about high insecurity context, it's usually because there is no political solution in sight. Think of the Congo, think of Somalia, South Sudan. It's been going on for years. And the problem that we face is that we deal with this crisis, and every year there's at least one or two additional crises. So this year it was Central African Republic and the Ebola. This is why it's always more, and it always feels like it was an exceptional year. So the accumulation of crises is definitely something that we feel very strongly and we experience very strongly, both in scale and in number of countries where we have to respond to violence. A second challenge is related to the slide here, is actually a constant need for simplified, adapted versions of medicine and tools. Because you can have the best diagnostic tool, the most sophisticated diagnostic tool will do no good in a place where there is no electricity. If the machine is very sensitive, we won't be able to use it. So we don't want to do the medicine for the poor. We don't want to use very basic stuff. What we want is to be able to take the best technology and to simplify it as much as possible and to make it field friendly. So for example, we want the latest vaccines, but we want these vaccines to be heat stable. We want these vaccines not to necessitate a heavy cold chain. We want these vaccines to be unidose. We want these vaccines to not to be needle free, because it's dangerous, because if you have a needle, you need trained health workers. Whereas if it's just a patch or a Listerine or whatever, then it's easier. So we're trying to look at what the new science is bringing, but also challenge the way it is designed so that it would be more adapted to the countries where we work. What we also want to challenge is the fact that, and I raised it earlier, the fact that when a disease kills millions of people, but that none of these people are in our countries, there is very limited investment in research. It's the case for the disease I mentioned earlier, but it's also been the case for HIV/AIDS until HIV/AIDS reached us. It's the case for TB, tuberculosis. There's been years without any single investment in tuberculosis because we thought it had been kind of eradicated in our countries. So we're trying to challenge this status quo, because there is nothing more frustrating for a physician not being able to treat patients because the drug is not adapted, or because it's too expensive, or because it simply does not exist. So challenging the status quo is, I think, very much part of the identity. And it forces us, therefore, to test constantly new regimens, to advocate for certain types of research, and to try to promote research and development based on needs rather than market opportunities. And this is something that in trying to define the most adapted tool, Google has played a very important role, and I hope that we can continue to find ways to get your your expertise. We have also engaged ourselves in the development of our own tools. For example, we've just finished testing a viral load point-of-care test for HIV/AIDS in Malawi. We are engaged in clinical trials, in Ebola clinical trials in West Africa. We believe we are in a good situation to test this, but we also don't want to subsidize the whole R&D community. And so it's always also a balance to find between where to invest our resources, how to take the opportunity of the cohort, the field, and the ability to advance the medicine we use with the need to actually challenge the system and make sure that research and development is made in this direction. And the last challenge that I'd like to share with you, there are many more, but I chose those ones because I thought they might be resonate more with you based on your field of expertise, is the logistics. Because even though we are medical organizations, nothing can be done without the logistic. And I know that someone in the room has his brother as a logistician in Monrovia as we speak, and he would be able to say more eloquently than I do how critical it is for every single aspect of the operations, from feeding the teams to setting up the hospital to ensuring the transportation and supply and everything. So logistics also requires constant adaptation and innovation. We have 3 supply centers for the organization. Again, 3, and it's a strategic decision, because imagine if we have just one supply center in France and there's a strike in France. What happens, right? So we realized very early that it would be quite dangerous to try to centralize this, and having 3 has proved very helpful, again for the Ebola, because the supply center in Belgium became overwhelmed, and we were happy to be able to use the other ones for it. So the supply center's role is first to identify the best tool for the fields. So they are constantly exploring the market, but also in a constant back and forth with the field. So imagine a physician from a Bellevue hospital is coming for a field assignment with MSF, and during his mission, he realizes that we use a tool that is not very practical, and he himself has used the tool in Bellevue that is much more convenient. So there are systems he would be in a capacity to actually write to the medical director and so on, and they are and who would transfer the information and then would ask the supply center to look for this type of tool. So we have a constant back and forth, and the catalogs are updated every year, and there are teams working on trying to improve and refine the tools that we are using in the field. The second role of the supply center is, of course, to ensure that there is sufficient supply in the long run, because it's not just about preparing an order, it's also making sure that the supplier is going to be able to catch up with potential increase in the needs. You've seen all these pictures with the PPE, the personal protective equipment that we used for the Ebola. Actually, there's been a very, very big issue in terms of supply, because we have identified one supplier as the best quality supplier for it, and this supplier has been constrained by production capacity after a few months. So this is really a challenge that we have to face for every single tool that we use, making sure that there is an appropriate supply chain. What we've done also, and what you see in these boxes, is we've created some what we call ready-to-use kits. So instead of having to send each item to the field in a separate fashion, we know what is needed to respond to a cholera outbreak. We know what is needed to perform an investigation of measles. We know what is needed in case of an earthquake. So we've designed some kits that we called measles kits, cholera kits, earthquake kits, surgical kits, that contain everything from the pen to the bucket to the antibiotics for a number of patients. So for example, we have cholera 1000 is a kit for 1000 people affected with cholera. So that the teams on the ground, since there is also a lot of turnover, they don't have to relearn about everything. If they know that they are facing a measles outbreak, they know that they just need to figure out how many people they need to cover, and they ask for a measles kit. And those kits are also updated constantly. And last but not least, the logistics centers are in charge of ensuring the safe transportation of the goods, which is another challenge, because it's not as if you're just using a regular airline and you take the next Delta flight from Paris to New York. It's really about finding your own planes, getting the authorization to enter some countries where it's not so easy, ensuring the cold chain also in those areas, and the logisticians in the field play a very critical role in negotiating the entry of the goods, especially the drugs, of course, because it's a sensitive item. So sometimes one obstacle might be that the boxes are stuck in the airport or the harbor for several days, and it's a matter of life and death, of course, that you receive the items. So this is why I wanted to insist on logistics, because it has always been an issue, but it is very, very difficult. In West Africa, for example, there were less and less airlines willing to travel there. So if you don't have a plane and some personnel ready to bring the supply, it's an issue. There are numerous barriers to access in a growing number of countries in terms of regulations and so on that make our work simply a big headache. So this is something we're working at, but it's definitely a challenge in every country where we work. So I want to finish with Ebola, because Google has been very much, the crisis team has been involved in it. You've supported us all along. And again, I'm sure you've read a lot about Ebola. So what I want to do is maybe to share with you more how we've lived it from inside. Because for me, Ebola exemplifies, this outbreak of Ebola exemplifies all the dysfunctioning of the system and all our own limitations and weaknesses. I mentioned the fact that we had made the choice of not investing in hemorrhagic fever, of just having a centralized hemorrhagic fever unit. Too bad. It was a bad choice. We've corrected it since then, but it was a bad choice. The Ebola outbreak also illustrated a demedicalized, not responsive humanitarian system. It took 6 months for organizations to acknowledge that there was an issue and realize the seriousness of it. It also exemplifies how risk-averse the community is to the situation. It's a disease. Ebola is a disease for which there is no drug, no diagnostic test, no vaccine. I mean, you can find worse, right? There's nothing to, so you had to invent. You have to create and try what works and what doesn't. And finally, Ebola happened in a country, which is what we experience in many places, where the health system is very, very weak, if not dysfunctioning. So you see on the map the number of programs that we've opened in those 3 countries. We've also done some work in Senegal, Mali, and Côte d'Ivoire, and Nigeria, mostly in the form of technical assistance. The ministries of health were willing and very strongly involved in trying to contain. They needed the expertise. So in those countries, we've actually provided this expertise and not engaged in a full program. And so far, they've been able to contain the outbreak. How we've lived it from, I will finish with the activities. So we're engaged in clinical trials, both for vaccines and drugs. We are trying to bring a sort of comprehensive approach to the Ebola outbreak, both in the form of treatment. And we can't even talk about treatment because there is no treatment, but it's more isolation center and palliative care for the sick patients. But also the community outreach, the contact tracing, surveillance, education. We've provided disinfection kits for the people to at least try to mitigate the risk of contamination if they have some sick patients among them until they are able to bring them to a health facility. The side effects are huge. The health system has collapsed, and actually we don't have the figures, but when we will do some studies, I'm sure we will be shocked to see the number of people who died of other health issues than Ebola, but because of Ebola, because the health facilities are not functioning. So what we did recently was to also distribute some prophylaxis against malaria, because first, at least people can be protected, and also because malaria has the same symptoms as Ebola. And if you have fever and you don't want to be in an isolation center, take the risk of being contaminated with Ebola if it's only a malaria. So we've tried to get engaged in those aspects. I don't see what's written, but psychological support and anti-malaria program I mentioned. Yes, psychological support is very, very much needed for the families, for the patients, and for the staff. I mentioned at the beginning that 90% of our teams are national staff. What does it mean? It means that in the Ebola outbreak, those teams have been there since day one. They are the ones, they have no break. Our international teams, they rotate every 5-6 weeks. But for our national staff, there hasn't been any single, I mean, there's been a few days break, but it's been extremely demanding. So how have we lived it from inside? I have to say that in the US, we've sent about 90 staff out of the 800 international staff that we've sent on this crisis. And I've never felt such a high sense of responsibility. Although we'll send our people to very dangerous places, but there we have security protocols, we have always a capacity to evacuate. It's one of the criteria when we open a program. We want to make sure that we're going to be able to withdraw and close. So, but in West Africa, we had no guarantee of medical evacuations, and that really consisted a very big challenge. The limited science was a big problem when you claim to treat patients, but you don't actually have a treatment. The high mortality rate in our center created a lot of frustration and tensions inside the organization. There was this big tension between clinical care and public health, because you want to isolate, you want to break the chain of the outbreak, but you also want to treat the patients. And you have to choose where you're going to put your resources. And I can tell you as we speak that there is a huge debate, a very heated debate inside the organization about the choices we've made and how to go about this. The cultural tensions around the burial practices were very, very big. The countries decided to go for cremation. It was very poorly accepted by the community, and we had to deal with that. Well, even when we know that the main source of contamination is through the burial practices. As we speak, we still have 70% of the people in our treatment center who've attended a funeral in the past few days. So, which gives a sense of how this is sensitive, but also a key in the management of the outbreak. But I want to finish on a positive note and say that Ebola also made us grow. We learned more on the disease that we've done in the past 20, 30 years, because we've been confronted with such a large-scale disease. We also take pride of having been there, standing with this population. I think that everybody in the organization feels very, very good about it, even though we're very frustrated. We have, one of you was mentioning the Business Week paper that prompted actually the invitation of MSF here today. We have fantastic stories of survivors. Everyone coming back from the field has amazing stories to say about solidarity, about mobilization. And finally, I want to believe that this global awareness, because finally the international community mobilized itself, the financial means, the fact that the scientific community is today mobilized together, I hope that it's going to be an opportunity for the system, for the global health system, to be more responsible, to be more driven by the needs, and more visionary about the future global threats. Now we'll stop here, and I'm happy to answer your questions.
My question is, how do you think organizations like Google Org that invest or support young startups in the social impact space can be helpful in, like, what can we do in the technology aspect to drive some of the gaps that we have identified?
I think that what you can do is clearly identify the gaps. So making sure that this is a gap, and making sure that it's gonna be helpful, either for us, but not necessarily for us. I think that being helpful for the communities, for the local NGOs, is something. We've had several discussions with Nigel, because they came with ideas sometimes, and they say, "What about this and what about that?" And we're saying, like, well, we're not sure there is a need there. We're not sure it's going to be helpful. We're not sure it's ethically. It might pose some ethical perception problems that are actually counterproductive. So I think that it's really about trying to understand where the needs are and how it can contribute. But it's more a conversation on a day-to-day basis, and with organizations that are involved on the ground. I'm sorry, I don't have a clearer answer to that, but.
How often do individual members on the ground breach your impartiality, and what do you do about it if they do?
I'm going to give you an example. I don't know if this policy is still standing, but for many years we had a policy that our international staff based in Gaza Strip could not stay more than 6 months. Because we had experienced that after 6 months they were losing their impartiality. Because they were under so much stress, they were exposed to a certain facet of the problem. And so the way we do that is definitely to anticipate the risk, but also when we are sometimes it's the person himself or herself who has to be evacuated because they can't stand it, and they don't want to, they don't trust their local partners anymore. They don't want to work there. I remember I worked in Rwanda in 1995 after the genocide, and I witnessed a massacre in Kibeho. It was the May 1995, and I was in the coordination team. I was dealing with the Rwandese authorities, and I was personally very shocked and disgusted by the way it was handled. And I asked the organization to stop my mission after that, because I didn't see how I could responsibly engage with the local authorities after what had happened, and I had lost my impartiality, let's say. So it's really more about responsible, and sometimes it's going to be your boss who's going to say, "You're losing it. It's better that you go back home."
Could I ask that people go to a microphone, because there are...
Maybe I should repeat the question, right? Sorry, I forgot. Okay.
I have a question regarding impartiality as well. So a few years back, there was a high-profile incident of the CIA using a vaccination program to gather genetic information and to conduct military strikes. How has that impacted people's perception of Doctors Without Borders, especially in Middle Eastern countries?
This incident, this tactic, let's say, has not had an immediate and direct impact, but has largely contributed to a growing perception against against humanitarian aid workers performing vaccination. But it's not just this tactic. We actually reacted against it when it happened. We expressed our concern by the fact that humanitarian aid and medical aid was instrumentalized, and so it is de facto more difficult to gain acceptance and trust if you claim that you're going to do vaccination and the CIA just came by a week before and using vaccination as a tactic. So, but in the incidents that happen afterwards, there's been a series of killings of vaccinators in Pakistan, but also in Nigeria. The CIA tactic is not the only reason for that. The approach of the global health community toward vaccination is also largely responsible, in our view, for the loss of trust in vaccination practices. The urge, for example, to eradicate polio and the amount of resources. So polio is not good. We all agree with that. We need to address polio, but there's been so many resources devoted to polio compared to other health issues that it also has created a perception that has contributed to the attacks on vaccination. In Pakistan, there are people who are suffering from a number of health issues, and they might not think that polio is a priority, right? So this is to say, in answering your question, that we are very much against and concerned by those practices of using humanitarian aid to cover military or political action, but that the discredit on health workers cannot be only attributed to those practices. We also have our own responsibilities when we choose the type of global health agenda and action that we put in place. And we have to make sure that when decided to enter in vaccination or eradication, it is also considered a priority for the communities that are affected by these issues.
Hi, you talked about evacuation earlier as one consideration before you set up a treatment center. Yeah. What are some of the other major questions that you think about before setting up a treatment center? And are there places that you simply won't send your staff to?
So your question is only about security, right? Or it's
Not
about the global criteria?
Yeah.
Okay. So evacuation is a criteria in a high insecurity area. It's not a criteria everywhere, of course, right? But the main criteria for deciding to open a center is mortality, of course. So how are we gonna have an added value? There can be high mortality, but we know nothing about this disease, right? So we can't do anything about it. So it's our own added value. And is there anybody else who can do it? Is another organization better placed to respond than us? So this would be the first criteria to decide. So the neglect is very important, as you see, because it's both, can we do something about it that others can do, and is it really killing people?
Thank you.
Yeah.
Hi. You mentioned the concept of operational neutrality and keeping your donations from governments to 15% to sort of safeguard that. What about investment neutrality? And what I mean by that is, well, I guess there's really two questions here. So number one is there government money that you're saying no to guarantee your operational neutrality? And then number two is the concept of investment neutrality would be, you mentioned the fact that there are a lot of things you would like investment in, but the problem is those things don't happen in maybe like the West, right? So there is an investment in those things because people don't see it. So is there a way to maybe, you're not taking operational money, but you're taking investment money that can be redirected to those causes?
Yes, there is. There are definitely investments that we wouldn't take from government. It's not just about taking funding from government or not. It's about, we may, for example, receive funding from DFID for some research, for medical research, but we may not want the funding from, we will not want the funding from DFID for Afghanistan, for example, right? So depending on the nature of the funding, we will make some arbitration. Is there a way to ensure, if I understood your question, is there a way not to get the money, but to ensure that this money is invested so that it serves our purpose, right? Yeah. Well, this is what we try to do through advocacy. And this is why I said we don't want to be constantly filling the gaps. If there is no drug for TB, it's not for MSF to develop a drug for TB, right? So we have developed a, we have dedicated some resources to our advocacy so that we can try to influence and mobilize the stakeholders, so big pharma, the large organizations like Gavi, like the Gates Foundations, and we have actually people who are working on trying to influence their agenda and making sure that they are paying attention to those aspects. We're also, where I think we are the most successful is trying to demonstrate that a protocol works, and then having WHO, the World Health Organization, adopt this as a normative protocol, because then it's the best way for the countries to demand that those protocols be applied. And when you have a protocol, you need to have medicines that also is adapted to them. We also worked at providing some specification. For example, we're working with a number of labs who are working at point-of-care tests, and we provide them with the list of the wish list of what would be an ideal point-of-care test in the countries where we work. So,
thanks.
I was wondering whether in MSF there's any group, small or big, related to information technology, basically our cousins, or is there any group in either absorbing technologies or inventing some for the scenarios served by MSF?
So we have in New York actually a team that has been asked to develop a health information system for the field, and I think it would be super helpful to connect you with them, definitely. We have a number of people working on some specific technology. So we have an information system, but I have to say that we're vintage in MSF on this, and it takes time to to get even up to speed in our headquarters with what would be the good system. So I don't think it's a good use of people like you to actually mobilize you on that. We need to catch up on a number of things in terms of our systems. When it's we're better at medical technology, of course, because this is our priority. We also have a number of people working on innovations in logistics. This is an area that is interesting. I've been supporting one of our teams who was asked to look, for example, after Haiti, at the management of waste. Because in most of the countries, you actually don't have the industry that can eliminate some waste, right? So we have our own incinerators, but an incinerator does not eliminate everything. So you need to we needed to figure out whether it was better to create our own management on site or to export our waste and make sure that it is done in a safe way in another country. And in the case of Haiti, we've actually concluded that it was better to re-export the waste, and it's been done. We had a contract with a company in the U.S. who has imported the waste that we made from Haiti. So there are so many different areas where we look at possible technical solutions. But in terms of telecommunication and health information system, it's really something we definitely welcome some support. And in terms of usual communication for the regular functioning of the organization, we are far behind, and we need to catch up before we can be a valuable partner to you.
So we say probably the last question, if that's okay, because we're coming up to the end of our time.
Real quick. One question, one request for comment. Question, what do you guys use for communication collaboration type technologies? Are you using Google Apps or Microsoft? Or what's your email?
It's Lotus Notes.
Lotus Notes.
So full.
We should talk. The second is any comments on the situation in Myanmar? I know you guys were in the news quite a bit on the Rohingya situation.
Yeah, it's a dramatic situation, and we're still in negotiation with the government. We have got the authorization to work in Rakhine State. So there's a line of communication with the authorities, but the acceptance on the ground is very, very difficult. So there is so much tension within the communities that even with a political agreement, it's very challenging to work there. The situation is explosive.
Thank you.
I was going to probably make a comment, having worked with MSF officers in the field over the years and had run my own, is that there's some very good reasons why Lotus Note persists in many organisations that operate in the field, partly because of the way it does synchronisation, though there are often better solutions now. But organisations still trying to jump out of that, figure out where to go. But that's one of the big constraints, is that they might be archaic systems in some sense, but the web just doesn't work in most of these places, right? I wish. But I was going to say that thank you very much for coming. I had a question myself, which is really about how you manage innovation, because humanitarianism is a very difficult place to do innovation because of the consequences. The downside risk is so huge, right? And you talk about sort of running in parallel situations as a chance for allowing different solutions to emerge. But one of the things I see, I'm on the board of the Humanitarian Innovation Fund, is that the way you organise that critically makes a huge difference for how things work. So that was going to be my question. We probably don't even have time for a lengthy answer on that, but I was just going to say thank you so much for coming, and we all really, really appreciate your insights and what you've been able to share.
Thank you. Thanks.